for this one, what you're simply going to do is on your phone or tablet, you're going to want to pick the color of the tiles that you'd like to choose that are the answer to this question.
I'll read the question if it helps. I guess it moves quite fast from the question.
It's interesting. I hope my answers are right.
You'll be able to provide the answers towards the post lecture. I've indicated them on there, so you'll be fine. All right, that's it for the pre-test questions. Dr. Estey, back to you.
Okay, so let me see. I gotta get my slides back. Where'd they go? There they are. So can people see the slides?
Yes.
Okay, so I'll start. So I really have nothing to disclose, and as a matter of fact, one of the things I learned many years ago, when we actually wrote a paper, an abstract, an ASH abstract, and then a paper, was the proportion of positive ASH abstracts that actually turn into valuable new therapies. And things may have changed since we wrote that. But it was striking how many abstracts are positive rather than negative. And of course, unless things have changed, it stands to reason that many of these things will not be able to be repeated, et cetera. So this will not be a talk where everything is promising and wonderful. So those are the topics. You can probably read them quicker than I can say them. The first, we're going to start with azacitidine or decitabine, which hereafter I'll refer to as HNA hypomethylating agents, although it's not really clear to me that's how they work, but that's a good abbreviation for them, HNA plus venetoclax. And this was not presented at ASH, but was published in the New England Journal of Medicine earlier this year. And I think it's really important to start with this and to recognize what was in the paper. So those are the eligibility criteria. Basically, you had to be over 75 in the assumption. So the general idea is we want people who are unfit for intensive therapy. And they're going to define that by people who are at least age 75. But of course, it's common knowledge you can have somebody who's 76 or 75 who's really very fit compared to somebody who's 65. So that's an immediate problem. And maybe the next slide, we'll get to the issues. And there's the randomization. It was 2-to-1 between azacitidine and venetoclax, or azacitidine and placebo. And then there are all these, the primary outcome was survival. And then there are all these secondary outcomes. And of course, you know, old people like me remember when there was really only CR. And now there are all these other responses, CRI, CRP, CRH, MLFS, and they're lumped together into what's called an overall response rate, ORR. And sometimes there's so many of these responses less than CR, I wonder that the ORR is not more than 100%. And of course, the question that arises is what value of any of these responses, aside from making the ORR higher? So here are the results, and you can see here are the combination of CR and CRI. And for both CR and CRI, let me minimize my thing. It was higher with the combination of azacitidine and venetoclax. And this is a major endpoint, and here is the data, and you can see that the results were better, statistically at least, with the combination. One of the things that I always look at is the median follow-up time. And here it's almost 2 years. And that's important because the question is, well, when can you consider the results, quote, mature? And many years ago, we considered this question for intensive chemotherapy, and we found that the risk of relapse did not really begin to decrease until you've been 2 and perhaps 3 years after you've been in remission. So even though 20 months is longer than some of the follow-ups that we'll show later, which are more like 6 months, the question is, how likely are these results to change? And it's really difficult to know. It does seem like it's fairly stable once you get to 24 months, but of course, the number of patients is very, very small. So every time I show things like that, I always caution people to take note of the duration of follow-up. And obviously, it's arbitrary what's too long and what's too short, but I would say that, you need a follow-up of at least 2 to 3 years to have some confidence of what's going on. And obviously, many of these people are 6 months, 9 months, et cetera. But so that brings the next question. And this is, I think, maybe the most important thing in their paper. And basically, you're looking at the hazard rate. And if you're to the left, that means that it's better if you got the azacitidine combined with venetoclax rather than placebo. And then the confidence limits are shown there. And so, for example, well, for everybody, the top one, it's obvious that the winner was the azacitidine plus venetoclax. But then you begin to look and you say, well, wait a second, in people who are less than age 75, was it really a benefit? Because the confidence limit crosses 1. And then you go to some of the mutations and the same question arises. And I think a better way to have done this is to say, okay, if you're age less than 75, where it was not clear there was a benefit, and you also have, you're unfit in one way or another, maybe it's beneficial. But at least if you're looking at this and just, in this very simple way of presenting it, it's not obvious that it's better to get venetoclax and azacitidine for terms of survival if you're age under 75. Okay, so here are some of the issues. And as I say, I try not to say everything is promising and wonderful, but I see my role, especially because I'm old, as being able to ask questions that people might, I'm sure, occur to many people, but, because they're not as old and that, they don't feel comfortable asking these questions. So the first is, how unfit were the patients? Because all these studies say the patient are unfit. But as I mentioned before, performance status, not age, is the most important determinant of treatment-related mortality, or TRM. This study said you could go on if you had performance status 2 or 3, I think. But at any rate, very few people either had performance status 2 or 3. I probably should say a 3. It was very, very few. So you say, well, how unfit were they? And then they list the various comorbidities. You could have this or that or this or that, but were they each equally important? And what's the effect of having 1 versus 2? So I think all these questions would make you wonder, were these patients really unfit? And particularly, do they match the patients that I would consider unfit? But there's going to be a randomized trial that's going to start, and it's going to compare. And of course, then the question is, if they're unfit, if they're really fit for intensive therapy, because what they're saying is they're unfit for intensive therapy. If they were really fit for intensive therapy, maybe intensive therapy would have done better. And Mohammed Saror and I published, or about to publish, something we think will be accepted in Blood that is a large retrospective and prospective studies, certainly not randomized, but suggests there's no necessary advantage to receiving less intense therapy, although we didn't include many people with venetoclax and azacitidine. But this question, which I think is a fundamental question, is going to be answered by a randomized trial that will soon start, and they're going to include people aged over 40. So in principle, if you're 42, you'll be able to get venetoclax and azacitidine. But more important than this, and I think the real point, is that there's conflation or confusion between medical and statistical significance. And this, I think, applies to almost everything. So as you saw before, that there was a 5-month improvement in median survival if you receive venetoclax and azacitidine. And that's undoubtedly important. Those additional 5 months might let you see, your grandchild graduate medical school or something like that. But if you look at U.S. Social Security Administration tables, which have to be accurate because they have to say how much money we have to pay out, you can see that the average life expectancy of a 75-year-old without AML is somewhere on the order of 11 years if they're a man and 13 if they're a woman. And then if you do a bit of arithmetic, you can see the 15-month median survival with venetoclax and azacitidine results in a loss of 85 to 90% of the life expectancy in the average 75-year-old. And I think that people are often not told that. But it's very important to be aware of that for obvious reasons, because there are some people who might say, okay, this is, how do I know that if I go into a clinical trial, it won't be worse? But there are other people who would say, what, this is so great? No, I'm going to lose 85% of my life expectancy. I'm happy to go into a trial. And without this information, it's really impossible for people to decide whether to go into trials or not. And obviously some do better and some do worse than the median. But, in fact, we can show that our ability to prognosticate is somewhere between the ability of certainty and a coin flip. So there are many, many problems in saying people's prognosis, which of course why they're randomized trials. But to me, we need continued trials rather than complacency. And one of the things that I wonder about is whether this publicity that surrounded this drug and the advertising that that goes into it will decrease accrual into clinical trials, and hopefully people will accrue into the randomized trial. So, but I think in recognition of the fact that HNA plus venetoclax is certainly does not cure the vast majority of older people and probably even younger people, there need to be some combinations. And so, so this is what's happening. So HMA and venetoclax are being combined with just about anything or everything, which of course I think is a really very good idea. And I think we can go over some of these abstracts that were shown here at ASH. So this one was an MD Anderson abstract, of which I'm a proud alumnus. I spent most of my career there after my wife retired from her job and said, I'd rather not live in Houston. So I moved to Seattle. So here is cladribine, low-dose ARC, and venetoclax alternating with azacitidine and venetoclax. And, if you look at it, wow, it looks really impressive. The CR rate was 92%, and most of the responses were without MRD. But then if you look at the survival curve there, you can see that most of the patients have been followed. The median survival is somewhere around 6 months. And again, if you look at figure 2, even though this thing looks really promising, you say, well, wait a second, what about people with adverse karyotypes, which are shown in the blue? But it's certainly an interesting study. Nobody would question that. So here are some of the studies with this issues with this study. The median follow-up was short. And I think a fundamental question is, when does the risk of relapse begin to fall after venetoclax? And as I mentioned, it's 2 to 3 years after intensive chemotherapy. So, hopefully these results will continue, but I think that remains to be seen. And another very important issue is people show survival. But one of the, and obviously that's the most important endpoint for the patient. But when you do a randomized trial, let's say somebody relapses, then they can get different kinds of therapy. Some patients may decide not to get any more therapy. Some patients may go on to get other therapy. And, the randomization then disappears because there's no assurance that people, after they get an event, will get the same therapy in the venetoclax arm as in the placebo arm. for example. And in the old days, it really didn't matter because once a person suffered an event, once they failed to go into remission and once they relapsed, they'd be dead in a few months. But if you said to me, Dr. Estey, what's the biggest change in treatment of AML in your lifetime? It's clearly the ability to keep people alive longer, not necessarily because the therapies are better, but because the supportive care is so much better. And hence it becomes possible that, whereas in the old days, event-free survival and survival were sort of the same, because if you were not in remission, you would die, you had no neutrophils. That's no longer the case. And because the survival can be extended long time you can actually see people live longer out of remission and in remission. And so that begs the question that the survival can be confounded with the therapy that's given after an event occurs in the randomized trial. So I think it's really always useful not only to look at survival, but also at event-free survival these days. So that takes us to another study, and all this is the theme of, okay, we're going to add things to venetoclax, which I think is clearly the right way to go. My take-home thing from all these, though, is curb your enthusiasm. And so here's CPX plus venetoclax and relapsed refractory AML, another MD Anderson abstract. And, there again, the median follow-ups are short, although here, the relapse-free survival looks great, but you can see that there is, one person after 12 years. And something that's really, I think, very, very fundamental. A lot of times these days, you'll see studies presented, this drug, that drug, but there's no comparison. And, I was taught that phase 2 studies are inherently comparative. Efficacy studies are inherently comparative. And, because if you don't know how the study compares with a previous study, how do you know whether you want to do a randomized study? So they have to be comparative. And here there's no control group. And it's not that difficult to do this kind of thing. Is you just do a multivariate analysis and say, okay, here's what people got in the past. And now we're going to compare our results in these patients and we'll adjust for various factors. And the most important factor in the past influencing results of salvage so-called therapy for relapsed or refractory AML was the duration of the first CR. And this study did not even mention that. And to me, and I think many others who are older, that's really remarkable because people have shown that this is always the most important prognostic factor. And the reason for that is that all the therapies bear a certain resemblance. So even transplant, if you look at the results of transplant, they are very influenced by cytogenetics and these days, particularly by MRD. So someone who starts a transplant and is MRD positive, they're much likely to do worse than somebody who starts a transplant and is MRD negative. And what does MRD reflect? It reflects failure of the previous therapy. So bad chemotherapy begets bad transplant. And of course, what that says is that there's some relationship between all these therapies. So even though, transplant has GVL and many other things that may make it better in many cases in chemotherapy, there's something about chemotherapy and transplant that's the same. Otherwise, the same people wouldn't do well and the same people wouldn't do poorly with either. And in the CPX plus venetoclax study, this is something that's really interesting. They say, oh, look at all the people that went to transplant. But one thing they didn't say in the abstract, nor in the presentation, I don't think, well, what were the results? Because you can have people go to transplant, but if they go in a suboptimal response and they relapse 3 months later, you say, well, what was the value of going to the transplant? Now they have GVH and they relapse. So to just say 7 of 8 go to transplant, that's fine, but without knowing the results, it's really sort of incomplete information. And then we'll get back to this, is what's the significance of responses less than CR? So hopefully we're doing okay so far. Should I just continue? We're okay? Okay, I'll continue. Okay, so this is another MD Anderson abstract, and really they do so much work. It's really very, very impressive. So this again is saying, okay, we are going to combine other things with FLAG-IDA plus venetoclax, and these are going to be obviously people they consider fit, and they divided them into newly diagnosed patients, which are the 27 shown in the next to last column, and then in their refractory relapse patients, which is, I guess, the second and the final column. And it's very impressive again. They have a 90% response rate, and most of the CRs are MRD negative. Now here's one where they do show post-transplant survival, and this looks good. But again, the follow-up is relatively short. And that's something that I should emphasize. If there's one thing that I would emphasize in all ASH abstracts is look at the follow-up. Yeah, and here we are. And something else that they said in the abstract, although I don't know if they said it in the presentation, is the median CR duration was 15 months. And knowing that you can get a CR rate of probably 50 or 60% after relapse in somebody whose remission duration was that long. So the question is, what would it be in people whose median duration, CR1 duration was 6 months? Okay, this drug I think has a bit more follow-up than some of the venetoclax studies that were presented, and I think it's probably the most significant drug in AML with a long enough follow-up. And so this is CC486, which of course is oral azacitidine, but you're not supposed to call it that, but that's the general idea. And there was a randomized trial of CC486 versus placebo in older people who were in CR or CRI after one or more courses of consolidation therapy. I always put consolidation in parentheses, in quotes, because to me, you're assuming that you're making it better when you're giving these therapies. You're consolidating it. For all you know, the things are getting worse. So I always call it post-remission therapy, but it's generally called consolidation therapy. 85% of the people in the study, and there are lots of people you'll soon see, were intermediate risk. And that's, of course, because older people with adverse risk usually don't go into remission. It's been approved by FDA for maintenance, this azacitidine, and that's fairly recent. And it was shown at ASH this year by Dr. Roboza. No, I forget. There are many people associated with it. And it was superior regardless of the number of so-called consolidation courses that people got. But of course, one of the questions is, everybody asks, that everybody realizes that really the goal is to get people to an MRD negative remission. And so the question is, well, what about MRD? Was it better in people who were only MRD positive or only people who were MRD negative, et cetera? So at the time of randomization, about, 2/3 of the people, 70% of the people were MRD negative. And that's more or less what you'd expect, because generally most remissions, at least with intensive therapy, and these people presumably got 3+7, are MRD negative. And so here is, this is Gail Robaza's graph. And so basically what you're looking at, so here, to their credit, they show not only survival, but relapse-free survival, which to me, the relapse-free survival is a better indication of the efficacy of the drug for the reasons I mentioned before. And you can see that, again, if you say, okay, we're going to look at that thing where it says multivariate analysis. So you account for things and then you say, yep, MRD positive does worse than MRD negative. So it doesn't totally destroy the influence of MRD positive. But after you account for that, the CC486 is better than the placebo. And in fact, if you look at the four graphs, you could sort of say, well, in a way, maybe people who are MRD positive who get CC486 do as well as people who are MRD negative who get placebo. I'm not sure that's the case, but that's the suggestion. So the point is that, it's valuable for people who are MRD positive as well as people who are MRD negative. Something that I think was a really interesting abstract was this number 11, and this is all from the big randomized study that was supported by, Bristol Myers, anyway, and Hartmut-Dohner presented this. So there are 78 patients who had 5 to 15% blast after beginning CC486 or placebo. And you would say, oh my God, they've relapsed, end of story. But what they did was they said, well, what would happen if we increase the duration of the CC486 or placebo from 14 days every 28 days to 21 days every 28 days? And what they found was that when they did this, there was a big difference, 25% versus, 15 or 12% in the proportion of people who went back to having less than 5% blasts. And the survival from the original randomization was longer in people in whom the dose was escalated than in the people in the placebo arm. So it's interesting for a couple of reasons. One is, I don't know if I mentioned this, but one of the things, well, maybe it's in the next slide. Okay. So, but a question that's interesting is, did the survival of those who did or those who did not receive escalation in the oral azacitidine and placebo arms, how did that compare? In other words, yes, you can get rid of the blasts by increasing the dose, but do you make them the same as people in whom the blasts never went up? I don't think that's known. So yeah, this is another interesting from Heart Donors abstract. So when they started, there were people who were MRD positive when they started the CC486. And the people who went, there were 39% of the ones who got CC486 went from MRD positive to MRD negative versus 19% in the placebo. And obviously, more people stayed in MRD negative remission in the placebo arm. But one of the things that's really interesting in this, to me, is because we're interested in looking at people with MRD and giving them drugs. That's a very, very popular field. We know MRD is bad. We'll give them a drug and see if we can get rid of the MRD, under the assumption that will improve their outcome. But that remains untested, because there are people who say MRD is really an epiphenomenon. It just indicates you have bad disease and you can get rid of it, but nothing will change. But that remains to be answered. But the interesting thing here is that you give the drug, you're in a single arm study, and you give the drug, and wow, 25% of the people became MRD negative. But if you look at the data here, you realize that if you do nothing, there are a certain proportion of people, here 19%, who became MRD negative after they were MRD positive to start with. So again, it's another word of caution for people who do MRD eraser studies, that there's a certain rate of people becoming negativity just with time. Yeah, this is another really important abstract from Constance Donor, also in Germany. And this comes out of the Ratify study, which of course was a study that led to the approval of midostaurin for people with FLT3 positive AML. And it's a really, tremendously important study. Largely due a lot to the efforts of many people, mainly Dr. Stone. And anyway, this FLT3 insertion site, it's where the ITD is I'm not a scientist, but it's where the ITD is what they're looking at. So they looked at it in about 80% of people in this study. And there are 3 potential sites on the ITD where this insertion can take place. There's the juxtamembrane domain site, about half the people had it there. And then there are these other 2 sites where it could also occur, including the TKD as the sole site. The important thing to know is that the midostaurin, which was beneficial in people with FLT3 AML, is beneficial only if there's the JMD site. And so I think what's going to happen sooner rather than later is, in addition to saying is the person FLT3 positive, is where is the insertion site? Because if the insertion site is not in the JMD domain, then probably you would not necessarily want to get midostaurin. So that's something that I think will become really an issue later on. And presumably tests will be developed to where you can analyze this thing relatively quickly. Oh yeah, okay. So this is a bit complicated, but this is an important question in the world of FLT3, which I guess we are in now. So, so there was a randomized study in people who had FLT3 positive AML and they relapsed. And they were randomized to gilteritinib or salvage chemotherapy. And the results came out that the results were better if they got gilteritinib rather than salvage chemotherapy. And I think that's the basis on which FDA approved the drug. But the question came up, well, wait a second, many of the people who had relapsed with chemotherapy had never received midostaurin. So the question comes up, okay, now the patient has received midostaurin and another FLT3 inhibitor, obviously. So they got 7+3 plus midostaurin, they relapsed. And now is the gilteritinib still better than people who had not received prior tyrosine kinase inhibition? And what you're seeing over there is that it appears to be the case. So in the bottom right thing where it says without prior TKI, you can see that even in those patients, No, I'm sorry, no, I'm stupid. The one with prior TKI is what you're looking at. So those are 45 patients who'd received presumably midostaurin and they relapsed. And the question is, even though they received prior midostaurin, is it better to be in the gilteritinib arm than the chemotherapy arm? And the answer is yes. So this actually, it's a question that I always used to ask is, well, what about people who received midostaurin? And they went and answered, and they said, okay, yeah, even if you've received midostaurin, it's better to get gilteritinib than chemotherapy after you relapse. Of course, somebody could again look at that and say, well, 6.5 versus 4.7 months is sort of a distinction without a difference. We still need, better therapies, but it did answer that question. So this is a very, very important and much discussed drug. It's called magrolimab. Hopefully I'm pronouncing it right. And this is a multi-center study, and that's the abstract number over there. And what it does is it blocks CD47, and presumably what CD47 does is allow macrophages to kill cancer cells. And no, it's the opposite. CD47 prevents macrophages from ingesting cancer cells. So by blocking CD47, this should allow macrophages to work. So, so they presented a study, and obviously everyone knows that people with TP53 AML do particularly poorly. So they worked their study to try to include lots of people with TP53 mutations in it, and that's why many of the people had TP53 mutations. They emphasized accruing those patients. And so you can see that the overall response rate is 69%. And, nobody would argue, though, with a 45% CR rate in people who are TP53 positive. And nobody would say, wow, they would say, wow, that's really impressive to get a 13-month survival in people who are TP53 mutated. But again, the median follow-up is short. And again, there's a question of the value of responses less than CR. And an issue that, I think seldom gets discussed is that one of the things, this was sort of like a phase 1 study just starting, and there was no MTD. And, old people like me remember the way you would do the study is you would discover an MTD, and then you would say, okay, we're going to use that. And these days people say, well, we're going to identify the optimal biologic dose. And the assumption is that you know perfectly how the drug works. And, and the one thing I wonder about is what happens if you don't. And now you're using something that you think is the optimal biologic dose because I know the biology of how this works. Well, maybe I don't. And if I don't, then really what you're doing is you're giving a dose that is not optimal because there's no toxicity. It's fine to have no toxicity, but people die because there's no efficacy mainly. And so one of the things I always wonder about is, I understand the scientific reason for using the OBD, that's obvious. But I'm not sure that in all cases we understand how these drugs work well enough to say, okay, we looked at this and inhibited this, so this is the optimal biologic dose, and we can go no further. We can just use this. And obviously the appeal is obvious. You can save time and presumably money on the part of the company by going right to the phase 2. But I think it would be really interesting one day if people actually did studies where half the people were randomized to start the phase 2 with the OBD, the optimal biologic dose, and in the others, you identified an MTD and randomized between those. I think that would be very informative, but it's unlikely to happen. There are other drugs that people should know about that are being used for TP53 AML. There's fludituzumab, which is it's a DART, which is sort of like a bispecific combination of CD123 on the AML cell and CD3, the T cell. They're basically like the same principle as blinatumomab. And then there's this APR-246 drug that's received a lot of attention. Although I didn't really see much about it at the ASH meeting, but that's a drug that there have been studies done, and there's almost certainly going to be an azacitidine plus or minus APR-246 study done in people with TP53 mutated AML. So that takes us to another question here is, okay, what's a way of managing people with TP53 AML? And this is another MD Anderson abstract, that's the number. And basically, what they identified with was that a variant allelic frequency, which is the proportion of, of alleles that are mutated, over 40% was very important. And you can see the top number A is showing the overall survival. Again, that's not necessarily the same as event-free survival, but anyway, according to whether people had a TP53 VAF over or less than 40%. And one of the questions that, that I asked, I think I love to ask questions at ASH meetings, but one of the problems with the virtual meeting is you could only ask one, and whereas at the regular ASH meeting, the presenter would respond, and then, you could say, okay, here's a follow-up, and you couldn't ask 10 follow-ups, you could ask one. And one of the problems, so one of the questions I asked here is, where did the 40% come from? And, they gave some long-winded statistical answer, but everybody who's familiar with, who's least bit statistically sophisticated would say, well, the only way you could really tell is if you tested an independent population. And that wasn't, I don't think, done. But anyway, the point is that what they showed was that if you are TP53 mutated and you get something containing ARC or cytarabine, you seem to do better than if you did not. Assuming, so in people who are TP, so what A is showing is people who got a cytarabine containing regimen did better if their TP53 was low. And whereas in contrast, it didn't make any difference of the opposite. So probably if people use this, they're going to base their TP53 therapy based on this VAF and give people higher dose ARC if it's low. I said that incorrectly. The people who benefit from the if your VAF is less than 40%, the people who benefit are the people who get ARC. If your TP53 is high, it doesn't matter what you get. So this, I think, is really, to me, I really like, this might have been my favorite abstract because it didn't involve new drugs and it didn't involve promising and all this kind of stuff that I always wonder about. So this is a huge study, a multi-center study involving lots of patients, and they divided them admittedly arbitrarily into younger, which was age 0 to 29, middle age 30 to 59, and older. And a question at the European Leukemia Net, if you're familiar with it, it's very widely used. And we didn't say anything about IDH mutations. The only mutations in the ELN 2017 are obviously MPM, FLT3, TP53, ASXL, and RUNX1. But there are a gazillion other mutations. And so somebody could very fairly say, well, my patient's IDH positive, and they have a normal karyotype. Are they intermediate risk or what are they? And so figure 2A basically shows that. And what it shows is on average, it doesn't really matter what your IDH mutation status is. And what really matters is your NPM thing. So in the green one, your IDH mutated and NPM mutated. And in the bottom one, your IDH mutated and NPM wild type. And just as you might expect, regardless of the IDH mutation, the NPM1 mutation does better. So that's good. But it gets really, really complicated, and we don't really need to go into these things. But what you're looking at is that certainly in certain patients, it doesn't matter. So for example, if you have a combination of IDH mutation and NPM mutation, you might say, well, that's really good. But if in fact you're also DNMPT3A mutated, then you're not so good. So, I think one of the things that people are fond of saying is, oh, okay, they have this mutation and therefore this. But the obvious fact is going to be, it's going to be incredibly complex, because it's not going to be just whether you have one mutation or even two. The most common combination is your NPM, which is FLT3, but it's going to be 3, 4, 5 mutations. And this is going to make it really difficult to do studies, because you're going to have 20 different subgroups. And, and then the question is, well, we're going to give these people of subgroup size 20 this therapy, and these people of subgroup size 10 this therapy. And the question is, how are you ever going to come up with answers that have respectable false negative and false positive rates? So I think at some point, we're going to have to disengage ourselves from this P less than 0.05 and 80% power, because that's not really compatible with the small numbers of patients we're going to have in various subgroups, unless you just posit huge differences, which are probably unrealistic. Okay, so this is the last one, and this is one that we did, and so it's sort of self-aggrandizement, but it's, I think, a really important topic. And so this is variations on CR in AML. And so there are the various definitions there. And the one that's most popular now, or is most recently in vogue, is CRH. And so the strict definition of CR is you have less than 5% blast in the marrow, and MRD is not regarded, although it probably should be. And your neutrophil count is between 500 and 1,000, and your platelet count is between 50 and 100. A looser definition is shown over there. And so the question we asked is, how often does this actually occur? So we looked at bunches of patients, and we've gotten this so far from the SWOG and from Australia. And you can see that, that the strict definition of CRH is so uncommon you can forget about it. And the looser definition is more likely to be. And once you start using the looser definition, there'll be fewer CRI and CRPs. And so the question is, well, what does this matter? So this is Meganophis, and basically what we're doing over here, and the thing to look at is the graphs, and these people have fairly long follow-up, I think, and so now we're looking at, okay, what's the influence of CRH? And so if you look, now you're saying, okay, here's a reference of CRH versus CR, and you're accounting for all these other things that people know are, important. And so if you look at the first line in the multivariate in the model there, CR is a reference and CRH is, you're comparing CRH to CR. And you look and you say, well, it sort of looks like they're the same. But of course, the truth is there are not very many people with CRH. And then you look at the last one, CRH versus no response at all. So no response at all means you live long enough, 60 days, to see a response, but you never got a response. So it's landmark, so-called, at 60 days. And so then you look at that and you say, well, it appears that maybe CRH is better than CR, than no response. The hazard ratio is less than 1. But the p-value is such that you're not really sure that CRH is better than no response at all either. So there's a lot more information to get. And I think one of the things, this is, I think, my last slide, is we have a little project where we're getting data from various places, the Alliance Group in the US and the British MRC and the partner donor AMLSG in Australia and Cleveland Clinic and ourselves. And we hope to be able to answer this question, what does CRH mean? And in particular, what do these various responses mean? Because I think it's easy enough to say ORR, or overall response rate, and obviously it becomes very high when you add all these things together. But the patient fundamentally doesn't care what you call their response. They're more interested in what does it mean for my future? How long do I live? How long is it before I relapse? So I think that's the last one. And now what?
We can go back to the Kahoot and do the questions over there, or?
Yeah, I hope that was what you had in mind. I'm not sure.
Yep, that sounds good.
Okay.
So everyone can just go back to the first game that they had on their phone or whatever, in case you got logged out. Here's the information. And I will go ahead and start the questions just in a couple of seconds. And Dr. Este, if you want to pitch in, say anything, feel free to.
Okay, so should I answer this question? You all want to go through your questions first, right?
Yep, they're the same questions as you had. I'm just going to put them up on here. All right. Feel free to read them out, whatever works for you.
Okay, you want me to read out the first question?
That might work better. Well, it moved fast.
Okay, yeah. So this is from the Bean Karki, I hope I'm not mispronouncing it. And it's a good question I should have mentioned. Oral azacitidine CC486 is FDA approved for maintenance of AML in remission, not transplant candidate. I don't see much use in regular clinics. Can you comment why the reluctance in adoption? Which group of patients do you think derive most benefit from this agent? So I think eventually it will pick up. I don't know, but that's my guess. I think it takes a while for that to happen. But the last question is really fundamental, because I think one of the things that would happen is people will say, I don't have to do a transplant because I can give this drug. And obviously there's more risk in giving a transplant than giving this drug. And, and so I think, one of the most important things the company can do is to say, okay, we're going to sponsor a randomized trial, if this would be practical, in certain people where we're not really sure that we want to do a transplant. So for example, we've shown in Seattle that if you get a CR and you have no MRD and you're an intermediate ELN risk group, that the relapse rate after transplant is very low. And it's so low that it would make you think, do I really need to do the transplant? Because the risk of the transplant is greater than the risk of relapse without the transplant. So that's a really fundamental question. And what you could do is take people where you're not really sure I mean, there are clearly some people where I would not probably give oral azacitidine. People, with adverse risk, ELN adverse risk, when they're transplant, I certainly would do a transplant. But there are people where I wouldn't be sure. And that's where I would want to do the randomized study. Because I think one of the possibilities is that, that's a long story. So, but when imatinib was first approved or whatever, Dr. Kantarjan would, work with him for about 30 years, and he would say, okay, STI, which was the original name for imatinib, stands for stop transplant immediately, STI. And of course, that did happen in CML. And so, of course, the possibility is that the access of this oral azacitidine, and I think it will be more widely used, will lead to STI when you don't want to do that. So I think, and I've told the company, I forget which, get the companies confused, is they should try to say, okay, here are people who are really not sure if they need a transplant, and randomize them between CC486 and the transplant. But I think that's a fundamental question and a very, very good question. Next, from Sushil S to everyone. You want me to read them? Okay, in regards to FLAG venetoclax study, did they use then? I think they did. What's my opinion on venetoclax maintenance in general? I think, I think most of I think the main problem with venetoclax from a standpoint is that, and I've heard a lot about this, is that people give it too long. So so I just, I don't see that many patients these days, and it's all via telehealth, but excuse me. So I just saw somebody and they'd been on venetoclax for 2 months straight. And of course their counts were really low. And so one of the things that I've heard people who use a lot, we don't use that much of it in Seattle for various reasons, but one of the things that I've heard people who know a lot more about it than I say is that it's much more myelosuppressive than people often admit. And so what the advice is, if you're giving it, is to give it for 21 days and then stop and then get a marrow a week or two later and then see what happens. But in maintenance, I mean, I've always felt the main problem is relapse, so I probably would favor giving it in maintenance. But the real question that I have about this drug, as I mentioned before, is that people are going to begin to think that, that it's the cure for AML, older AML, and it most certainly is not. And then the fear is, well, then we'll give everybody it, and then we'll never make any progress if people are referred for trials. Not that I'm, totally disinterested. Obviously, I'd like to have people referred for trials. But I'm always impressed. I always like that slide, the Social Security slide, where instead of losing, you still lose 85 to 90% of your life expectancy. Okay.